class. We're going to construct an effective initial management plan, including selection of appropriate antihypertensive medications. But we are learning hypertension in pediatrics. And remember that management is very important. Let me stop my sharing and share with you again what the medical council expects from you. Management. After you've done your assessment and diagnosis, right? That's why we spend so much time on if you see this and that, what are you thinking about? If you see this and that, what are you thinking about? After you've done that, the next thing you should expect is what? Management. Doctors, are you following me? Everything I'm teaching you is deliberate. It is deliberate because we are going according to the objectives. And it is deliberate because we're also using this as the guiding tool. That's why we learned about communication. That's why we learned about professional behaviors. That's why we've learned about how to promote healthy weight in the children. And that's why we learned that you have to be careful about the language you use. But you realize that according to this table, if you take hypertension in children, if you take obesity in children, how you assess and diagnose them, if somebody is supposed to quiz you, they will focus more because it's like it is more weighted than management, right? Before communication, that don't use the word chubby and all those things. Then when you come to dimensions of care as well, acute and chronic, before psychosocial aspects. So doctors, you are in the right, you're in the right group and we are doing the right thing. Don't fear at all. We're going to get you to the shore, all right? Good, okay. So, management of hypertension. Whenever you have to deal with hypertension, that's why I put it in capital letters. All children with hypertension and at any stage of the hypertension need non-pharmacologic options for management first. Or what I mean is, no matter what you do, the management plan you give them should contain non-pharmacologic options like weight reduction, like regular exercise, like restricting sedentary activity, like dietary salt restriction, like smoking cessation if they smoke at all. And then pharmacologic management of hypertension, always consider the stage of the hypertension first before you bring in pharmacologic management. But one form of management which should cut across all the stages should be what? Non-pharmacologic approach. Doctors, are we all on the same page? Because remember that what were the stages of hypertension? We have normal blood pressure, we have elevated blood pressure, then we have hypertension stage 1, hypertension stage 2. But from elevated high blood pressure to hypertension stage 1 and hypertension stage 2, for all of that, you have to still talk about lifestyle, non-pharmacologic. But it is not everybody that you use pharmacologic therapy for. Everybody must get non-pharmacologic, but not everybody must get pharmacologic. That's what I'm trying to say. To give somebody pharmacologic treatment, it must depend on a stage. So this is it. Again, remember this table. Elevated blood pressure, stage 1 hypertension, stage 2 hypertension. We reviewed this when we started the game, and I've brought it back again. Now, if the blood pressure is normal, it's normal. If it is elevated blood pressure, then that's one, no pharmacotherapy. No pharmacotherapy. Doctors, I say it again. If it is in a child with only elevated blood pressure, and what is elevated blood pressure? Elevated blood pressure is if the systolic blood pressure is between the 90th to the 95th percentile, or the blood pressure is 120 over 80 millimeters of mercury to less than 95th percentile. That one, just use non-pharmacologic stuff. Don't give any medication, please. Don't give any medication. Doctors, please. Number 2, if the child has stage 1 hypertension, then you want to do lifestyle changes for 6 months. Please write it down. Lifestyle changes for 6 months. And if it does not improve after 6 months, then you want to do the pharmacotherapy. Even that one, you still continue the lifestyle changes. Remember, lifestyle changes cut across all the stages of hypertension management. Right? If the patient has stage 1 hypertension and they are symptomatic, then that one, so far as they are symptomatic, start them on pharmacotherapy, but don't forget to let them continue their lifestyle changes as well. Then stage 2, pharmacotherapy plus non-pharmacotherapy as well. And if they have any neurologic symptom like, stroke or anything, then that's one emergent specialist referral. Because don't forget that in the objectives as well, one of the things they always put last is indications for specialist referral. So when am I going to refer the patient right away to a specialist emergently? If the patient has hypertension and also has neurologic symptoms.
Dr. Bruni?
Yes, please.
Yeah, please, can we just see the table for the
Sure.
thank you.
I think it will even be good if you can take a snapshot of that.
Yeah, that's what I want to do, please.
Yeah. Okay, good. Okay, so if it's neurological deficit, then you want to quickly get a specialist involved. Now, because the objective also talked about choice of hypertensive, antihypertensive, right? Always start with a single agent first. Always start with a single agent. Now, when are you going to add another antihypertensive? If the initial drug dose reaches the highest recommended level, or if that single drug you're using, the patient starts developing side effects, then you want to add on something else. What's the commonest second line, not first line, second line antihypertensive? Diuretics, thiazide diuretics, like thiazide diuretic, like hydrochlorothiazide and indapamide in children. But for primary hypertension and even like your first line, ACE inhibitors, ARBs, and calcium channel blockers. So I gave losartan to a 12-year-old child, and then 2 weeks later, I checked 3 days later, I checked the liver renal function test, and the creatinine was 3 times what it was before the patient started the antihypertensive. What is my diagnosis?
Yes.
AC induced.
AC induced what?
Oh, okay, sorry. Sorry, renal artery stenosis.
Renal artery stenosis, yeah.
No, but there's a part where they say it's due to the AC inhibitors and
we'll get there. We'll get there, don't worry. Okay. So if a patient has hypertension and has renal vascular disease, then you know that we'll use calcium channel blocker rather, because we said hydrochlorothiazide, is it first line or second line?
Second line.
And then we said that ACE inhibitors and ARBs and calcium channel blockers are usually first line, right?
First line.
If I have somebody with renal artery stenosis, I know that ACE inhibitors and ARBs are a no-go area for me. So then I'll go with calcium channel blocker, right? Because you know what, there's concerns of a reduction in glomerular filtration rate with ACE inhibitors and ARBs. Number 2, if somebody has hypertension with chronic kidney disease, what medication will I give? I'll give an ACE inhibitor and ARB.
ACE inhibitor.
Because that reduces the progression of chronic kidney disease, right? And I'll need to monitor the renal function. What if the patient has hypertension, a child with hypertension and diabetes? What will I give? ACE inhibitor plus
ACE
ARB,
inhibitors.
right?
Or ARB.
ACE inhibitor plus ARB. That's exactly what I'll do, right? And then, okay, I have a question. Can somebody read this question for me?
You are evaluating a sexually active 16-year-old female in the pediatric nephrology clinic. She has a boyfriend and is sexually active. Her blood pressure is 170/90 millimeter of mercury. You will like to start her on an antihypertensive. Which agent will you prescribe? Choose one. A, amlodipine, calcium channel blocker. B, cardesatan, an ARB. C, ramiprid, AC inhibitor. D, hydrochlorothiazide, a diuretic.
Okay, let's break it down. Which one will you choose? A, B, C, or D? and why? I think from this lecture, everyone knows that D is not our first option.
Yeah.
Why A?
A.
Why A?
Because
That's fine.
ACE inhibitors causes teratogenic effect.
Sorry, I can't hear you. Your voice is very muffled. Why
A is a calcium channel blocker,
Okay.
and calcium channel blockers are among the first-line antihypertensive.
What about
you're,
Candesata?
but you're suspecting that she might be pregnant.
Beautiful.
So you want to give a drug that is safe in pregnancy.
Beautiful. You've landed in glory. The reason why, even though this patient can take Candesatan or Ramipril and amlodipine, but you're going with amlodipine. For hydrochlorothiazide, it is out. Why? Because it's second line for pediatric hypertension, right? But then the reason why we are going for
amlodipine
is because the question told you this girl has a boyfriend. This girl is sexually active. So chances are that this girl may be pregnant. You see the way people are thinking through the questions. Look, there's no information which is put in your question stem which is irrelevant. Frankly, tonight, I think I can sleep well. So we chose amlodipine because calcium channel blockers as ACE inhibitors and ARBs are indicated in pregnancy because of known teratogenic adverse events, right? So ARBs and ACE inhibitors are contraindicated in pregnancy. For hydrochlorothiazide, it is second line. This patient has not even started the first line yet. So then amlodipine is the best choice. Okay, next question.
You are evaluating a sexually active 16-year-old female in the pediatric nephrology clinic. She has a boyfriend and is sexually active. Her blood pressure is 170/90 millimeter of mercury. You will like to start her on an antihypertensive, but she refused. You are concerned about complication if this is not managed. List 3.
So look, if we're going to keep this question very simple, it is, what are the complications of uncontrolled hypertension? All the English I've written. The question is basically, what are the complications of uncontrolled hypertension? And what are they?
Pregnancy with hypertension.
No. We are just talking about, we are not saying she's pregnant. We say she's sexually active, but we are avoiding those medications because she may be pregnant, right? But then if somebody is not taking antihypertensives, what can happen? What can happen to the brain?
Stroke.
What happen to the heart?
Retinopathy.
So they can have
left ventricular hypertrophy.
So they can have left ventricular hypertrophy. They can have congestive heart failure. They can have a stroke. They can have kidney failure. They can have an issue with the eye. Doctors, I think we've already done. Oh, yeah. Sorry. So that's very good. So you have to learn the complications of hypertension if it's untreated. Poorly controlled hypertension and untreated hypertension, left ventricular hypertrophy, congestive heart failure, stroke, renal disease, retinopathy. Right? Now, I have a quick one on renal artery thrombosis, and I think this is a very important question. Can somebody read for us? Please, I need somebody to read for us.
Dr. Bonnie?
Yeah.
Yeah, for this patient that you just, the last question, because of the additional information of her age, she's sexually active and all that, you suspect that she may be pregnant. Is it okay to also consider the specific complications of hypertension in pregnancy?
Well, but it said,
even though you have not confirmed that she's pregnant yet.
Yes, but I'll rather prefer to talk about the general complications of hypertension first. Okay. And if I exhaust that and I have more space to write, then I'll talk about the then I'll talk about the complications. Yeah.
Okay.
Again. So please, can we land our plane in glory? I need someone to help me with this case.
A 14-year-old.
A 14-year-old boy was brought to the emergency room with flank pain.
We
Continue.
don't have clothes. You already.
Please read the case.
A 14-year-old boy was brought to the emergency room with flank pain, nausea, vomiting, fever. His blood pressure was noted to be 168/95 millimeter of mercury. On further history, he has hematuria and a urine dipstick shows proteinuria. You decide to request a lab investigation which will aid your diagnosis. What blood work will you request?
Now hold on there. What diagnosis are you thinking about? You see, this is how I always want to.
Renal
Glomerulonephritis.
No.
Glomerulonephritis.
Oh, okay.
Nephrotic syndrome.
Nephrotic syndrome. You are thinking about edema and all those things. But remember, I told you when we started the class that there's a particular diagnosis that if you're not careful, you may confuse it with pyelonephritis and kidney stones.
renal artery thrombosis.
Necrosis, I
Renal
guess.
artery-
Artery thrombosis.
Yeah, renal artery thrombosis.
I
That
told you
leads
that.
to necrosis.
I told you that when we started the class, that there's one diagnosis that if you're not careful, you may confuse it with pyelonephritis and kidney stone. Yes, I understand the patient has nausea, the patient has vomiting, the patient has fever. But pyelonephritis on its own, will pyelonephritis cause hypertension? Tell me the truth.
No.
Sadly. So the blood pressure should tell you that there's something more happening than pyelonephritis. Will pyelonephritis cause gross hematuria or hematuria?
No.
You may pick up some blood in the urine, like if you do a urine dipstick, but the patient may not necessarily see gross blood when they pee, right? So please, no pyelonephritis, yes, but then pyelonephritis will not present with increased blood pressure. So we're thinking about renal artery thrombosis. Will CBC make any big difference?
No.
No, no,
So I rule out CBC. Will ESR make any big difference?
No.
no,
Not really, because it's non-specific. Will CRP make any big difference?
No.
No,
no.
not specific.
Serum creatinine make any big difference?
No.
Yes.
Yes.
Well, it may tell me that the
Yes.
kidney is in trouble, but then that is all it will tell me. But then if I want an initial investigation, which will lead me in the right path, because if a patient has pyelonephritis, I'm not expecting the LDH necessarily to be high, right? But if the patient has renal artery thrombosis, I'm expecting that the LDH may be high. So let's review renal artery thrombosis quickly. The patient will present with acute flank pain. There will be an acute elevation in the blood pressure. So that's why I was saying that is where you should use to distinguish between renal artery stenosis, renal artery thrombosis, and pyelonephritis and kidney stones, right? The patient may present with hematuria, proteinuria, nausea and vomiting, and they may have fever. And I think a lot of people went with pyelonephritis because we are all conversant with pyelonephritis, and it's like an infection, a very bad infection of the kidney, and because of that, we know there's trouble. But note, in the appropriate clinical setting, an elevated serum lactate dehydrogenase, LDH, is strongly suggestive of renal infarction. Hello! That is why we went through that question, because I wanted to bring you to this teaching point. How are you going to diagnose renal artery thrombosis or renal infarction? Contrast enhanced CT scan. Doctors, how are you going to manage it? Localize occlusion and localize the occlusion and restore the blood flow. Okay, so the thrombosis is happening here, right? So you're going to localize it and then restore anticoagulation, thrombolysis, percutaneous angioplasty, surgical thrombectomy, and antihypertensives. Now, tonight, I want you to do this for me, please. Review these two topics because we couldn't review it in class. Wilms tumor and neuroblastoma. What has been your learning points today? I want to know. What has been your learning point?
How to differentiate the blood pressure in the child according to the symptoms,
Good.
sign and symptom.
That's good. That's good. That's good. That's good. And then who else? What have you learned tonight?
The
I think
number
this last
13.
point you just made
Right.
is key for me.
It's key for
What is it?
Being able to differentiate how a patient presenting with renal artery thrombosis could actually mimic pyelonephritis, kidney stone, and all that.
Beautiful. Beautiful.
It's a major key point for me. Yeah.